What is thoracotomy? Tube thoracotomy is the most commonly performed surgical procedure in thoracic surgery. It is defined as insertion of a tube into the pleural cavity. A chest tube can help drain air, blood, or fluid from the space surrounding your lungs called the pleural space. It's typically an emergency procedure. It may also be done after surgery on organs or tissues in your chest cavity. During chest tube insertion, a hollow plastic tube is inserted between your ribs into the pleural space. The tube may be connected to a machine to help with the drainage. The tube will stay in place until the fluid, blood, or air is drained from your chest. Chest tubing may need if a patient have a collapsed lung infection, bleeding around the lung, especially after a trauma such as car accident, fluid buildup due to another medical condition such as cancer or pneumonia, breathing difficulty due to a buildup of fluid or air, surgery, especially lung, heart, or esophageal surgery. Inserting a chest tube may also help the doctor diagnose other conditions such as lung damage or internal injuries after a trauma. Chest tubes aren't placed in the lungs but in the pleural space.
Traditional water-sealed chest drainage system or wet suction has three chambers: the collection chamber, the suction chamber, and the water-sealed chamber. The collection chamber acts as a reservoir from fluid draining from chest tube. It is graduated to permit easy measurement of drainage. The suction chamber. A vent in the suction control bottle is connected to a vent on the water seal bottle. It regulates the amount of negative pressure applied to the chest. The amount of suction is determined by the water level. It is generally at 20 cm water. Adding more fluid results in more suction. The water seal chamber. It is filled with sterile fluid up to 2 cm line. Has a one-way valve or water seal that prevents air from moving back into the chest when the patient inhales. There will be an increase in the water level with inspiration and return to the baseline during exhalation. This is referred to as tidalling. Intermittent bubbling in the water seal chamber is normal, but bubbling can indicate an air leak. The water in the water seal chamber reflects the negative pressure present in the intrathoracic cavity. A rise in the water level indicates negative pressure in the pleural or mediastinal space. Excessive negative pressure can cause trauma to tissue. The multiple bottles and numerous connections of the typical 3-bottle system result in a bulky bedside device, which can be prone to accidental disconnections and blocks in the system. These systems, therefore, have been largely replaced by commercially produced, disposable plastic multifunction units that fit into a single box and work on the same principle. It is called the multifunction chest drainage system. The kits are designed to incorporate the functions and improve on the safety features of 3-bottle drainage system. They offer patient protection with effective drainage, accurate fluid loss measurement, and assistance in detecting air leaks. It also has 3-chamber system: the collection chamber, the water seal, and the suction control chamber that has the same function as traditional water seal drainage system.
Temperature 35.6 Celsius. Pulse rate 89 beats per minute. Respiratory rate 20 cycles per minute. Blood pressure 120/80. Gas exchange is determined by evaluating oxygenation and ventilation. In the immediate post-operative period, this is achieved by measuring vital signs at least every 15 minutes for the first 1 to 2 hours and then less frequently as the patient's condition stabilizes. Cuffing technique will be effective when you elevate the head of the bed at 90 degrees or let the patient sit with the foot resting. It is difficult to cuff in a supine position. Therefore, the patient is helped to a sitting position on the edge of the bed. Cuffing is necessary to remove retained secretion. It should be performed 1 to 2 hours for the first 24 hours. To be effective, it should be low pitch, deep, and controlled. If audible crackles are present, it may be necessary to use chest percussion with the cough routine until the lungs are clear, to help loosen and remove mucus from the lungs.
After helping the patient to cough, the nurse listens to both lungs anteriorly and posteriorly to determine whether there are any changes in breath sounds. Aerosol therapy is helpful in humidifying and mobilizing secretion so that they can easily be cleared with coughing. The patient's progress to full diet as soon as possible. Small frequent feeding meals are better tolerated and are crucial to the recovery and maintenance of lung function. Pain after a thoracotomy may be severe, depending on the type of incision and the patient's reaction to and ability to cope with pain. Lidocaine and prilocaine are local anesthetic agents used to treat pain at the site of the chest tube insertion. Emla cream, which is a mixture of two medications, has been found to be effective in treating pain from chest tube removal. Emla cream works by numbing the surface of the skin for the short time.
The entry site should be covered with a dressing such as Offsite 3000 to enable the site to be reviewed for signs of redness, oozing, and swelling. These dressings should be changed if contaminated with blood or aspirate, or every 7 days if clean and dry and a dressing is still required. to prevent infection around the site by keeping the entry site clean and dry. Clamp the drain tubing cleaned and reconnected and a chest X-ray carried out. A full set of observations should be done, taking particular note of chest movement and work of breathing, and a saturation should be done.
If the chest tube and drainage system become disconnected, air can enter the pleural space, producing a pneumothorax. If the chest tube accidentally falls out, instruct the patient to perform the Valsalva maneuver. At the end of expiration, immediately cover the insertion site with sterile gauze and occlusive tape. Place oxygen on the patient and sit patient in high Fowler's position. The nurse should immediately call the physician and prepare for reinserting of the chest tube. If the chest tube accidentally separates from the drainage tubing, wipe the exposed end of the tubing with an antiseptic and reconnect. If contaminated, cut the end of it and reinsert, and then notify the physician. Explain the procedure to the patient. Prepare new occlusive dressing. Remove the dressing. Remove the sutures. Instruct the patient to inhale. Pull the tube and apply the dressing while patient is breathing out. As soon as physiologically possible, usually within 8 to 12 hours, the patient is helped to get out of bed. The patient begins arm and shoulder exercises to restore movement and prevent painful stiffening of the affected arm and shoulder. Hold hand on the affected side with the other hand, palms facing in. Raise the arms forward, upward, and then overhead while taking a deep breath. Exhale while lowering the arms. Repeat 5 times. Raise arm sideward, upward, and downward in a waving motion. Repeat 5 times and repeat on the other arm. Place arm at side. Raise arm sideward, upward, and then overhead. Repeat 5 times and repeat on the other arm.
Extend the arm up and back, out to the side and back, down at the side and back. Repeat 5 times and repeat on the other arm. Place hands in small of back. Push elbows as far as possible. Press down on hands, consciously pulling the abdomen in and stretching up from the waist. Repeat 5 times.
Respiratory distress is treated by identifying and eliminating its cause while providing supplemental oxygen. If the patient progresses to respiratory failure, intubation and mechanical ventilation are necessary. These arrhythmias are often tolerated to the effects of hypoxia or the surgical procedure. They are treated with antiarrhythmic medications such as amiodarone, plecainide, ibutylide, clonidine, or magnesium and supportive therapy. Pulmonary infections or effusions often preceded by atelectasis may occur a few days into the postoperative course. Bronchopleural fistula is a serious but rare complication that prevents the return of negative intrathoracic pressure and lung expansion. Depending on its severity, it is treated with closed chest drainage, mechanical ventilation, and possibly talc fluorodosis. Hemorrhage and shock are managed by treating the underlying cause, whether by reoperation or by administration of blood products or fluids. Pneumothorax may occur after the thoracic surgery if there is an air leak from the surgical site to the pleural cavity or from the pleural cavity to the environment. Failure of the chest drainage system prevents the return of negative pressure in the pleural cavity. It is often accompanied by hemothorax. Pulmonary edema from the overinfusion of IV fluids is a significant danger. Early symptoms are dyspnea, crackles, bubbling sounds in the chest, tachycardia, and pink frothy sputum. These constitute an emergency and must be reported and treated immediately.